Welcome, EGP learners. Here's your primary care and general practice update for mid-May 2025. In today's episode, we will be talking about a BMA document that spells out the value of a GP, something useful for those making the case for general practice across the wider system and for appropriate funding for us. We'll be talking about another team up in the health technology landscape. Tortus and Exxon are combining forces, and we will be talking about a document that has come out called the Model Integrated Care Board Blueprint version 1.0, which will be of interest to anyone who interacts with an ICB, which is just about all of us. So let's get going and take enhance your primary care and learning.
Hello, eGP learners, and welcome to this episode. Myself and Andy are going to be tackling some fairly different but meaty things that have come out in the past few days as we try and help understand the landscape of general practice as it changes. How are we doing there, Andy?
Yeah, I'm doing pretty good. I'm excited to talk about these, as you say, quite varied topics. For those just joining, we'll be talking about the value of a GP, a BMA document, making the case for how valuable general practice is. We'll be talking about another team up in the health tech world, Tortus and Exxon joining forces, and then we'll be looking at a blueprint for Model Integrated Care Board, which will be of interest to, well, potentially all of us, because we all interact in some way with our ICB, and we know that they're going through huge cost reductions and restructuring at the moment, and this is a document that will be guiding a lot of the thinking about how they adopt their new post restructure shape. So I think that's a really interesting document to take a look at as well. But yeah, you okay?
Yep, ticking on and keen to get cracking on some of these news stories. So great as ever for those of you that are joining us live. If you do want to comment on what we're covering and talking about, feel free to do so. We love to hear from you, and absolutely let us know what you think about what we're talking about today. Also worth knowing what you think about the value of a GP. Actually, do you think GPs are valued or not, and whether or not this particular document that we're going to cover first is going to be of use to you or not. So we're going to get started with the BMA's value of a GP document. This came out on the back end of the LMC conference from last week, the UK version, and unfortunately wasn't able to attend, which was from what I heard, it was a very positive, very direct conference and very well valued by those who attended. But we'll see if that reflects in terms of the value of general practice itself, shall we, Andy?
Yeah, one of our salary GPs went to the conference and he had a really good time and came back sort of, bristling with ideas and enthusiasm for making the case for how valuable we are and how actually we probably do more than we are contracted for within the system, and think about how to continue to push back on that. Industrial action stopped, but I think people are very much keen to not allow general practice to be, I think he was talking about being taken advantage of to a certain extent by other bits of the system lent on. So still some of those thoughts going around. But yeah, do you want to lead us through the document, Gandhi? I know you've had time to have a look at this.
So it's not too long. I think it's about 11 pages in total, and that includes the appendices and stuff. And basically, it's a really good, direct document in terms of setting out the situation as well as setting out some of the ways to fix where we are. It doesn't make any specific asks in the sense of numbers or anything like that, but one of the things I have found from this document is really good at giving you the information and the evidence about what is happening and what could happen in order to improve things as well. So for that reason, I think it's a really powerful document.
So how might people use this document, Gandhi? What's the utility, do we think?
Well, so as you mentioned, collective action on a national scale has changed because actually the GPC have agreed that the national contract for currently, and they agreed to step down national collective action. But actually part of it is what they're suggesting is there's still local collective action. And I think also this is directed, to be fair, at the national perspective with a view for the 10-year plan and for the fact that actually there are some key factors. If you value them, they will give a return on investment that is far outweighed by what you would end up spending. And actually that's why the general practice and GPs in particular need to be valued in order to deliver that moving forward. So, I mean, the first part basically sets the scene and talks about the current situation, and it's got really good detail. It talks about some of the significant challenges in terms of the numbers of GP closures, GPs leaving the country. It then talks to a degree about the number of appointments being provided, as well as also the number of patients per full-time equivalent GP. I think it says it out 2,200 something, somewhere on there. I can't remember the exact number. There we go. 2257 per full-time equivalent GP, which is crazy. In fact, I remember, Andy, a few years ago, me and you doing a story where we were saying that 1,800 patients per registered GP was a significant amount.
It's really high, isn't it? And I think it makes some reference to how that's increased since 2012 by 38%, which is a lot. And that's about the time probably we were beginning to be partners. So that's a huge increase.
Massive increase. It talks about the fact that general practice is delivering an amazing capacity aspect in terms of 30 million appointments per month, which are being delivered in this and last financial year. But also actually there are really significant challenges in terms of what that means. So, you know, the later point mentions there in Wales, an average of the equivalent of 60% of the population sees a GP a month. That is crazy. A huge number of appointments being provided, even though, and I appreciate there are many out there who still feel that there's just not enough capacity to deal with the healthcare needs.
Yeah, and I mean, and that's why there's some statistics here about very or extremely stressful job in terms of how people report their job in general practice. You know, there's no reason, there's good reason that GPs are feeling stressed given all these appointments. So yeah, keep going, Gandhi.
Yeah. So then it continues to set out the situation and talks about some of the weird idiosyncrasy we've now developed. And so we're in a situation where, you know, we need more GPs, but actually GPs are out of work and unemployed and can't find work because of the financial situation that we're sat in and stuff. And therefore the issue is how do we improve that? So it then does talk about potential aspects that can happen. So number one, and the priority seems to be valuing continuity of care. And it repeatedly talks about this value, that valuing continuity of care is the key thing, that if we can do that, we will have better healthcare. So it talks about the fact that general practice has always been the cornerstone of continuity of care, you know, the cradle to grave aspect of things. And also sets out the study information that's come out recently in terms of, I think maybe jumping a little bit in terms of the Al-Wudi, was it? Al-Gamadi, which is in the later sections, about the impact of continuity of care as well. But it shows that this, you know, link between sustained relationships and general practice is there, and that whilst we are seeing some productivity gains from things like technology, and we're going to talk about a news story later on that has some of that embedded into it, that actually it's still, the workload is still there and there's still complexity that needs to be dealt with, and that you can't just rely on technology to fix the problems. It is about trying to maintain that actually the workforce is looked after, cared for, and still being able to have an impact. And that actually that will have an impact in terms of reducing secondary care spend, which I know is the thing that every place worries about as well.
Yeah, it's interesting that, I really like that they're quoting some studies that demonstrate, you know, it's the Starfield et al. 2005 showing that continuity is linked to higher patient satisfaction, improved treatment adherence, reduced hospitalizations. And then there's this more recent paper, Porshank et al. 2024, which demonstrates that when patients consistently see their regular doctor, the time until the next appointment is extended. And then also in this paper, it talks about seeing the regular GP significantly reduces visits to emergency departments as well. Yep. So continuity could be the secret sauce, you know, for solving
access, and it even makes reference to the fact that actually the focus has been on access, not on continuity, because access is quicker, sexier. It's the thing that, you know, people say that they want, but actually what we know is that continuity married with access actually works so much more effectively when you prioritize that continuity of care.
I think also, and you know, what you hear most from patients is, I can't get an appointment to see my GP, and you can interpret that in a few ways, can't you? And I think what we've responded to is the ability to see any GP or member of staff at a practice at short notice. We've interpreted it in that way, but I think many patients actually mean, I can't see the GP that I normally see, you know, my GP.
Mm.
And actually, I think people have been asking for that as well, but we've really only solved that kind of immediate access to any member of staff at the GP surgery problem, rather
Mm.
than focus on continuity, and you know, which probably delivers more improved outcomes than just the access alone.
Mhm.
Carry on. I believe in
Well,
continuity.
yeah, it talks about this. It's in the next page then in terms of patient health outcomes and experience. So it focuses even more on the aspect of that continuity driving forward better healthcare. And that, you know, this unfortunately has reflected in some of the more negative aspects that we've seen. So, for example, the reduction in trust in general practice as a result, you know, and the value that people are commenting in things like the GP patient survey and other kind of surveys and things. But that actually, where people have been able to prioritize continuity of care, where there's been a greater investment in general practice, actually the compound benefits of that have been significantly better, both in terms of life expectancy and in terms of spend. So it mentions those in that particular section. And, you know, it's not rocket science. It really isn't. We know this works if you do it properly and not focus on other things that people unfortunately do tend to get focused on.
Yeah, this is actually great in that it pulls together a lot of papers showing the value
Yes.
of continuity. So I'm certainly going to have a look at these papers actually, because I often say, oh, there are studies that have demonstrated continuity, but it's great to have them all pulled together in one place. So I'll be having a look at those. There's all sorts of studies from different places. Yeah, but carry on, Gandhi.
Yep. So we move down in terms of valuing quality of care. It then talks about improved equity and prevention. So this part features more in terms of tackling the aspects of making sure that the resources are seen where it needs to be, and that actually general practice is most suited at helping with prevention of illness, which is one of the key derivatives. We know that we want to move from treatment I always get this confused from
Illness to prevention.
illness to prevention. That's it. Yes. Apologies. That we, you know, that's one of the key of the three drivers of, you know, the new NHS moving from illness to prevention, and actually general practice is best suited for delivering that, because in terms of our accessibility, in terms of our relationship and community care aspects and things that happen. So, you know, it puts real focus on, again, that aspect when it's twinned with the fact that actually areas of, for example, health inequality, significant deprivation, do not see the same level of funding equitably to provide those services. And that's why they have worse outcomes. And it's not because they're not working hard, it's because they don't have the differential income and resources to provide that same level of care because of the challenges they're facing from the populations they look after. And actually that needs real significant looking at.
Is this making a case for fairer funding models, do you think, Gandhi?
Effectively, not just in terms of funding, but also in terms of time. So there's a key paragraph in here that it talks about the time of a GP appointment. So it talks about the fact that actually still in many practices, they focus on only having 10 minutes and potentially even less. And actually the growing evidence shows that you need considerably more than that to support patients with the level of complexity we're now seeing. So moving even past 15-minute appointments is potentially suggesting, I think it puts a spread of something like, there it's in the later paragraph, 15.7 to 28.4 minutes for a GP appointment. You know, that's significant changes in things. And that actually, if you focus on providing better quality, that actually you will have better outcomes as a result of it. And it's important to recognize, and we're going to talk about this later, the future of the NHS is not moving about activity, it's talking about outcomes. Yeah,
absolutely.
And then it talks about the next section, which is valuing our workforce. So a couple of aspects in this. One is in terms of actual well-being, recognizing the immense amount of stress that people are under currently working within general practice, in terms of, you know, the way that they're perceived, the way that, you know, they're working, and burnout being a real challenge for many professionals across the board. And that, you know, this is because of the higher intensity workload, the left shift of workload from out of hospitals into community care, and actually some elements of tech helping, but at the same time, tech uses a different word, tech overload or something like that. I can't remember the word it uses. Yeah, I'm gonna have to find it now, aren't I?
I'm struggling to pick it out here, Gandhi, but I'm getting the concept from you as well. And you know, I think I sometimes experience
Techno stress. That was it. I found it. So
stress.
It's in the third paragraph on that page, techno stress, that people are seeing in terms of, just the cognitive overload of having to use various different things. And we see this day in and day out in practice, don't we, Andy? How many different systems are you and I having to engage with just
log
to do
into,
patient
use,
care?
Yeah, just to get through the day. One system is a system for
Mm.
ordering tests, viewing results. Some people have different systems to looking at their letters. There's the clinical record that we record into. Often different systems for clinical triage. Absolutely. It's really confusing.
It is. And it's growing in terms of the impact of that. So, it's talking about how that many people, because of this impact, in terms of the stress, in terms of the challenge, they're just leaving. And we're seeing a greater numbers of people leave as a result of it. Then talks about practice clinicians. And this section seems to focus more in terms of skill mix and the fact that actually we are moving towards different levels of clinicians being able to see patients, and whether that's a good thing or not. I guess this is the focus on particularly things that we've seen and reported on previously, like physicians associates and other kind of roles. And it specifically does mention that evidence in the second paragraph, the evidence that long-term showed physician associates for significantly longer consultations compared to GPs, on average about 5 minutes more compared to a GP, and the reconsultation rates are considerably higher as a result of that compared to GPs and things. So therefore, focus on the fact that, actually the overall output income of spending on the GP is probably better in terms of paying for physician associates and things, because of these additional aspects in terms of time and reconsultation rates and stuff, even though they may be cheaper.
So the overall cost effectiveness for output is lower according to some of this evidence. That's really interesting, isn't it?
It is. I think, the different perspectives may exist in that particular commentary, but I think, at the same time as well, it's recognizing that, some of the information that we have in terms of benefits and cost effective analysis is trickier to understand. And that's something that we haven't seen a huge amount of. So it's interesting to see that here.
Yeah. And I guess people might feel the calculus on physicians associates perhaps looks different when we have a workforce shortage of GPs, and there isn't a way to deliver that kind of service because of a lack of GPs. And as we move into an environment where there are more GPs, the calculus of people deciding on their workforce may be different. But equally, this is based on that evidence. Other people's experience in terms of how they deploy physicians associates may be different. Sorry for interrupting, Andy.
Not at all. It then talks about properly funded service. So the part I love the most about this is that great commentary about the fact that additional £1 investment in NHS primary care has a return on investment of £14 of additional value to the economy. So it's the Wood and Gorgham study from 2023. It makes reference to that, and that actually, if that remains to be true, and it probably will, in fact, it's probably going to improve in terms of efficacy as time goes on. Why would you not want to spend more money in general practice? Because actually the return on investment is clear. And actually commenting that in some areas where they have done that, they've seen lower admission rates to hospitals, they've seen lower complication rates in terms of patient care, and they've seen better access overall in terms of healthcare provision as a result of it. So it really does emphasize that. Interestingly, it's also got a metric I haven't seen commented in quite a long time, and that's the cost of a GP consultation.
Okay. So yeah, how much does it say we cost?
Yeah, go on.
I'm used to maybe thinking figures of £30, that sort of figure, but
no, £56.
Okay.
Yeah,
more than I remember. Yeah.
Yeah. So I often comment on the PSSRU data, which used to value roughly a 15-minute consultation about £40. So it has gone up a little bit from there. But this is in comparison. So the lowest level of investigation treatment in urgent care centres is £91. So you can almost see twice as many patients in general practice as you can in an urgent care scenario. You compare that to an A&E scenario, which is probably going to have even higher costs. Then actually there is clearer evidence that shows that we would prefer, from a system perspective, it is considerably cheaper for patients to see in general practice. So actually, again, bang for buck, you're probably better off investing in general practice than spending money on big UTCs, spending money on A&E departments, because the capacity and impact benefit is far better in general practice.
I can see Yeah, this is really, really good information for those people who need to make the case, for general practice,
Mhm.
whether they're talking to ICBs, the general public, politicians. It's a really good handbook. If my MP was coming to visit the surgery, I'd be reaching for this document and making a few notes from it.
Absolutely.
It's really helpful.
Yeah. So, and it talks about the fact that even the public were happy to invest in more time and more money into supporting the NHS. So, a recent survey found 46% of respondents were supported raising taxes to increase NHS funding, and that actually, if that the summary of this is, if that funding is put into general practice, we will see a return on investment that far outstrips any other part of the healthcare system. And that's not just national data, that's European data, other data as well across the world that shows that if that was to be the case, then actually this is real benefit to everybody. So it talks about the fact that finally that general practice has the expertise to lead the healthcare system moving forward. But what we need to do is we need to value general practice, we need to value our GPs, and we need to value the healthcare of our population. And the best way to do that is invest in general practice.
Yeah. Okay. Here. So yeah, really quite powerful document. I've got a few questions for you about it, Gandhi.
Let's go for it.
So, and I've got thoughts about the answers to these as well. But
so just before you ask your questions, I'm just going to say to anybody watching us, if you've got questions as well, now's the time to ask them, because then we can go to them when Andy's finished asking his stuff and things. So please do chuck them in there.
Yeah, it's interesting. So why do you think we're getting this document now, in terms of this information's been around for a while? I'm just curious. I like to try and read the runes in terms of what the BMA is up to in terms of its wider strategy and plan. Why are we seeing this particular document at this point in time, do you think, Gandhi?
So I think there's a couple of reasons why we're probably seeing it now. Number one, it came off the back of the LMC UK conference. So, where else would you want to release a document that values the general practice? Absolutely, you want to do that at a big event, and the LMC UK conference is one of the biggest events in general practice. I think it is on the back of the negotiated GP contract. So, there was a clear ask that the GPC had from West Streeting that they wanted him to commit to a wholesale renegotiation of the GP contract, which the government have committed to. So now there is that push to what does that potentially look like? And surely if you're going to make a case for better investment and all that kind of stuff, now's the time to make it, especially right before the release of the 10-year plan.
Yeah, I think I agree, Gandhi. I wonder if Katie Bramall-Stamer and her team at the BMA have have a grid on the wall. I've been listening to some political podcasts, and they talk about communication strategy and the grid, and it's about kind of what documents are coming out when, in response to other things that are happening on the calendar, in order to build to an event, to roll the pitch, as they sometimes say, to prepare things for then what you're going to send down the pitch in terms of the balls you're going to play and how you're going to play the game. So there may be an element of rolling the pitch,
Absolutely.
I think, here, which is great. And it's a really helpful document for anyone who needs to make the case for general practice, and pulling together all of that information in one place and all of those references is really, really helpful. And there's a really long, reference section at the end. And who do you think the audience is, Gandhi? Because it's well referenced. It gives it a bit of a kind of academic kind of feel. Who is this for, do you think?
So I'd probably go with the fact I think this is for the politicians. This is for the policymakers. This is for the ICB people. This is for Department of Health, West Streeting, absolutely. But I think also this is something that can be used locally by teams. Like I said, this was released at the LMC UK conference. This will be in the hands of every LMC representative that attended that conference, that then goes back and talks about the conference to their fellow LMC representatives. This is something that you should be shouting about to your local teams and saying, look what can happen if you invest in general practice. Move that shift of focus away from secondary care, move it towards primary care. If you do that, you will have return on investment. That's what it's talking about in my mind. Yeah, absolutely. We've got a question come through. Interesting question. Yeah. Jason Fury. Yeah. So if we're so efficient, are we too cheap? It's part of us being so good value that partners haven't seen pay rises in lines with the rest of the staff and other sectors. Now, I think that's a valid comment. Although interestingly, Jay, and I know you've commented before, in both me and Andy, when we talked about that cost of a consultation, we pitched it a lot lower than what the evidence shows in terms of what it actually is. So maybe there is something about that we are devaluing ourselves in general practice a little bit.
And it's good to get updated data, because I mean, I'm probably quoting some BMA data from 15 years ago or something. You know, maybe it did cost £30 per appointment in the past, and it's quite telling, isn't it, that I've not revisited that in my mind, and that I might be making time and motion kind of judgments and judgments about whether we can deliver services at certain costs and tariffs based on old data. So it's really helpful when the BMA provide updated figures. Yeah, it's interesting. I guess we don't know quite how we'd have to go into the paper to work out how they'd costed that. But if it's based on current costs and the current kind of, pay and rewards aren't in the right place, then it stands to figure that the figures might be a bit low as well.
So that was off some RCGP documents in 2024 from what it looks like. I can't find the exact one right now. So yeah, it'd be worth having a look at that one too at some point, Andy. Maybe that's a future document for us to cover.
Yeah. But so excellent. Have you any reflections to take away from this, Gandhi, over and above what we've discussed?
Like I said, I think for me, this is worth the time of our EGP learners to take some attention to. And I think it is worth discussing this in your practice coffee rooms. I think this is worth discussing with your LMC representatives. I think this is something that should be shared and discussed more widely, because I think there is real value in understanding the value that we bring to the table in general practice. And it's rare that you see documents that combine all that information in one go. I do see this as a very positive document. I know it talks a lot about doom and gloom and the challenges that are faced and that kind of stuff. But if you want to genuinely see what could be possible, this starts to open that door in terms of that. And I think, like I said, this is something I'd be shouting about. This is something I'd be sharing as wide as I could. Hence why we kind of put it on the channel. But yeah,
the most kind of interesting thing for me in terms of what's in this document is the emphasis on continuity. So I'm going to be looking at that, and we've seen increasing mentions of continuity in kind of policy and planning documents over the last 1 to 2 years. So I'll be really interested to see how continuity features in the 10-year plan. And I suspect it will feature quite highly, actually. But that might give us an indication in terms of how much Department of Health is listening to BMA and GPC. If those two things link together, particularly if it's talked about in a similar way, that just might give us an indication in terms of the influence, which will be really, really interesting, which might then feed into what we might anticipate for the contract, and whether there'll be incentivization or priority given to continuity in the contract coming up. And maybe this gives an indication that actually in those contract negotiations, we're looking for a focus on continuity, prevention, health equity, valuing staff using technology responsibly and avoiding techno stress, and looking at the skill and role mix in general practice and ours potentially, and really looking at the funding model. So those are things that I'm taking away as in terms of maybe that's what we'll be driving for in the contract. I think they have said separately that they're looking for similar things out of the contract. They're not shy about what they're looking for. So absolutely. It's really interesting.
Definitely. Bit different to our next story, isn't it, Andy? In terms of
it is. Do we need to just go and sit on that sofa for?
We do indeed. Well, let's go join those two sitting on the sofa, shall we?
So, Gandhi, while we're taking a break on the sofa, I've got a question for you.
Okay.
Our practice has been looking for ways to make things run more smoothly, better, more efficiently, improve patient care, and ideally to make a little bit of extra income as well. And I was wondering if you found anything that actually helps.
Yeah, so we've been in similar situations. Managing long-term conditions taken loads of time. So, there are various tools out there, and the one I would definitely suggest to have a look at is Primary Care IT. It's made such a difference.
And so, that's interesting. how does it fit into and work with your existing systems?
Well, that's the cool thing. It integrates with all the clinical systems that we've got currently, so TPP, EMIS, and Medicus as well, if you've got access to that. And they work really well rather than adding that extra step, because you can launch them through the systems.
And I've heard about the QRISK-3 calculator. Do you use that?
Yeah, so I know it's already built into EMIS, and they're looking at TPP integration soon. And then the benefit of having that straight away is the fact that, you know, it's integrated straight away. You can get the risk scores without having to switch back and forth between all the websites and the other kind of tools and stuff that takes so much longer.
Oh gosh, that is a headache. So I'd love to avoid that. Sounds really useful. But what about support? You know, new tools can sometimes be more hassle than they're worth.
Definitely, but I think their support is really solid. They have loads of onboarding to the support that you can have, webinars, resources that you can access as well through their website as well, and regular contacts that you can use.
That sounds really good. Sounds like something that we'd be interested in as a practice. How would we get started?
Well, I'd definitely check out their website. It's primarycareit.co.uk. That's basically where you get all the information you need, their contact details, as well as demonstrations of what they can do for you in practice, and also what's coming soon as well.
Oh, fantastic. We'll get started.
Definitely will. So, Andy, lots of cool stuff as ever from Primary Care IT. And actually, they've got some risk stratification tools to help you understand things like continuity and that kind of stuff as well, built into the toolkits that they have as well. So useful to know. Speaking of providers, though, we've got an interesting story that came out on the back of one that we covered a few weeks ago, which is a partnership between two quite interesting partners, isn't it, Andy?
It is, yeah. So Tortus and Exxon Health are partnering up. Well, I think Exxon are purchasing Tortus to bring them into their family. It's really interesting to see another. I like to call these team ups, like you know, when two superheroes team up for a movie together. It's really interesting to see, and as I say, we've seen the story of who was it last time? It was AccuRx.
AccuRx and Tandem was last month, a couple of weeks ago, and then this time we, like you say, we have Exxon, which provides the product Surgery Connect, and Tortus, which is another ambient voice technology or AI scribe technology platform, working together to bring an integrated solution that's called Surgery Intellect. Or Tortus Surgery Intellect, I believe is the actual name, to primary care, starting initially in 10 ICBs and then expanding from then moving forward through June 2025. So yeah, another interesting change happening in general practice, and particularly focused on ambient voice technology.
Yeah, it's really interesting. So we, as ever, we sometimes do a little bit of digging about the companies involved. So Exxon are owned by Southern Communications Group. They do appear to be a UK-based company with a turnover of 160 million pounds per year, which is interesting. And I think Tortus we think is founder owned. Don Pimenta and Christopher Town we think were the founders. We're not entirely sure. So correct us if we're wrong. And you know, so we're a user of Exxon. I think a lot of practices in the Nottingham area are, and this is actually really exciting. So I'm excited about this, perhaps more than I was with the AccuRx Tandem team up, because I can sort of immediately see how we are already recording many of the interactions that we have with patients with Exxon. Those that we're not recording, because we don't record our clinical consultations currently, are going through the system. So it's a great place for an ambient AI scribe to sit and deliver added functionality on top of that call that's already going through you know, a digital process and a digital interface, you know, in terms of all those things that we've seen Tortus and similar products do at demonstrations in transcribing the consultation and then summarizing notes, producing letters, and doing all sorts of time-saving things. This is pretty interesting, I think. What were your initial thoughts around this, Gandhi?
I think it's very interesting. So the first significant partnership we saw with this was obviously, like we talked about, AccuRx and Tandem. So that was online consultation provider and ambient scribe technology. This time it's now cloud-based telephony provider and ambient scribe technology. So I guess the only one left would be system provider and ambient voice technology. So the question is whether EMIS or TPP are now looking at a partnership with somebody to bring that.
Who's left to partner with, Gandhi?
Well,
they're quite big themselves, aren't they? But
not forgetting that Anima is already directly integrated with its own platform in terms of online consultation. So you could argue they beat Accurix in tandem to that particular type of partnership. But Accurix claim that obviously theirs is considerably larger given the market share that they have. I think in terms of, there are other providers still out there in terms of ambient voice technology. I guess other ones that haven't, as far as we're aware, have partnerships in this way would be Heidi Health, Kiwi Pen, T Pro. I believe there's a few others as well coming to the market or already in the market as well. So, you know, it's a growing market area. I think we did our Christmas episode and I predicted we'd see more partnerships, if you remember right, Andy. And look at what's happening. Yeah, consolidations and partnerships is happening and things. But I think this is an interesting one because of the fact, like you said, the ambient voice technology partnering with a cloud-based telephony provider just makes sense. It really does. And I wonder if the other cloud-based telephony providers are already, if not already, looking at these kind of technologies. The key question is going to be cost, because it's whether this is going to be included in the existing cost or whether this will be an additional cost to practices to utilize. And I would imagine there would be an additional cost. I can't imagine this would be, you know, per gratis in terms of the existing costs that are there.
Unless they can use it to kind of differentiate themselves from the other cloud providers to boost their market share initially by offering it for free and then cost at a later date. I find it really interesting how these companies kind of team up where they feel they have synergy to like add value to their product. It's really interesting. And as you say, the next thing is to throw a clinical record system, you know, into the mix, you know, telephony, clinical record system, ambient scribe, almost the full stack of what you need. Yeah, fascinating.
Definitely. So I think, again, it'll be a watch this space. I think keen to hear what the pricing is. So we don't have the official pricing for the Tandem Accurix partnership. We don't have the official pricing for the Surgery Connect Tortus or Surgery Intellect, as it's now being called, service yet. So when they come out, I think that'll be interesting to compare against the independent costings of these other platforms. You know, recognizing some of them are cheaper than what the existing platforms may charge individually. So it'll be, I think, a really interesting world. And the biggest question as well is still, where's the money to all this going to come from? Because the practices still have to find funding for it because it's not under a national framework.
Depends on cost, doesn't it? And I guess people will say, or the products often say, this saves you time and time is money. But as you say, whether that fully accounts for the cost, it's quite difficult to evaluate, isn't it?
Interesting times.
Yeah.
I'd love to hear from the eGPlearners what they think in terms of this particular announcement and whether they've got a preferential product that they like to use and thoughts and stuff. I know that recently I put some content out around another provider and people keep asking me for my templates and stuff. So just to mention that some of that content will be coming out shortly for people. So definitely if you want to see tips and tools on how to use Ambient Scribe, make sure you're subscribed, because otherwise you won't get to see that straight away as soon as it comes out and stuff and things. And as ever, ding, 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 ring the bell. Cool. Next story, which is probably the big one that we were going to talk about, which is the Model ICBs. Why don't you lead us into this, Andy?
Yeah. So we're covering this because it's in the public domain now, although it looks like it might have been linked to the Health Service Journal, but it's out there. It's found its way to the public domain, and this is a really interesting document which provides some thinking about the future of integrated care boards. So, I mean, what does it cover? So it talks about a number of areas. It talks about defining the purpose of ICBs more tightly and why they exist. It talks about defining the core functions of ICBs, you know, what they are going to be there to do going forwards. Talks about enablers and capabilities that need to be in place to ensure that they're successful. And there's quite a big section about kind of managing the transition from what ICBs may be doing now to what the guidance suggests ICBs should be doing in the future. Key phrase within this is strategic commissioning, if you could sum it up in 2 words. And they talk about developing really a sort of the key functions, really. So strategic commissioning, it sort of describes as sort of understanding what is needed, developing a plan to deliver it, delivering it by commissioning it or allocating resources to the plan, and then monitoring and evaluating the impact, and then continuing to then understand what the new situation is, and having a continuous sort of improvement and quality loop. And I guess people might be thinking, why does this matter to me? And actually, your practice, if you're not a partner or you're not involved in primary care networks or interacting with local or national or regional leadership, your practice will be interfacing a lot with the ICB, because they're involved in local contract management and estates planning and all sorts of functions that are needed. So it'll be a particular interest to those people working within ICBs, and some people might be watching the channel. And I think we have to be careful how we talk about it, because there is speculation about whether certain roles continue or remain within the ICB. So we just have to be aware that we're talking about potential people's roles, people's jobs here. Obviously, ICB leaders need to be and probably are already aware of this document. It's probably already informing decisions that are being planned, and as we say, PCNs, practices, all sorts of other people need to work with ICBs. They do all sorts of things, and increasingly will be involved in managing our contracts and performance going forwards. So so buckle in, and let's take you through what is in this document and some of the key things that caught our eye. So shall I keep going, Gandhi, or do you have any observations?
No, keep going. So
if people out there have any thoughts, obviously pop them in the chat and we'll bring you into the conversation. Thoughts and questions. At this stage, we can only really respond with speculation and opinion. So I'll just kind of summarize. There's a number of sections. There's an introduction, there's context setting. They talk about why ICBs exist. They talk about functional change at ICBs. And those are really the main elements. So people will be aware that ICBs have been asked to reduce their costs. There was an ask to reduce by 20%, and then another ask to reduce by 50%. So we're talking about ICB running costs, what they do at ICBs themselves, not the overall kind of budget for spend on healthcare for individual people. People might say, what are some of the figures involved here? So just for context, so like the per person spending on health in the UK is about £3,064. I think that's 2023 or 24 figures. ICB running costs have been variable in different parts of the country and running between £49 and £21 per head. And let's talk about getting all ICBs within a cost envelope of £18.76. So there will be reductions across the board, and perhaps more heavy in some areas than others. I'm not quite sure, whether some areas are being asked to cut more than others. As I suspect, if there's a large variation in initial budget, then that will be the situation. So there's lots of restructures underway, and this is informing the kind of the shape of what people are restructuring to. ICBs have to submit plans, I think, by the end of May about their cost reductions. So there's an important deadline there as well. So what does this document do? Well, as we said, it's seeking to clarify the role of ICBs. How's this document been produced? So they say they've taken a number of key leaders from ICBs and other parts of the NHS and NHS providers from systems of varying sizes, different performances. So it's not just the high performing ICBs, and they've done some like accelerated policy development with them. I think it's taken 2 to 3 weeks for them to come up with this. So it's kind of really quick work to produce this document. If only people always worked that fast, I guess. But hopefully that means that it's a solid document. They haven't put any feet wrong. There's some allusions to what might be in the 10-year health plan. So the 10-year health plan will require a leaner and simpler way of working. Okay, 10-year health plan to set out more detail on the wider system architecture and clarify the role and accountabilities of trusts, systems, and the centre of the NHS. Great. And they also say, right, we're sharing this now without the benefit of wider engagement with staff and stakeholders. So that's just speaking to the sensitivities that they've said that wider engagement will be required to get the detailed implementation right. So they're being sort of sensitive to that. Have we got a comment from Dave? Shall we go to that?
Yeah, absolutely. So Dave McConnell talking about how much money was wasted in creating ICBs to now essentially restructure without admitting a restructure. Interesting to see how it will be possible to devolve these functions down to providers.
We'll talk about where functions are going later on, Dave, and be interested to hear your ideas on that as ever. And yeah, we always seem to be restructuring, and some of what this begins to look like looks potentially like structures that have existed before, as we continue to reshuffle deck chairs potentially. Okay, so we have the introduction, and then there's sort of the context setting area. So they just remind us that ICBs were established in 2022. So we're kind of 3 years into the ICB project. Functions are planning and arranging health services for populations and holding the responsibility for performance and oversight of the NHS services within their footprint. Also system leadership and commissioning roles, and some other kind of delivery functions around emergency planning, safeguarding, NHS continuing healthcare assessments, for example. Interesting that sits there. I guess it has to sit somewhere, and provision of those services to patients with high and complex needs. They say that there's been kind of differing kind of interpretations and different forms of what ICBs do and what they focus on. There's been a lot of variation, and often there's talk of reducing unwarranted variation. So there's certainly an element of clarifying the ask in order to do that. And they quote Lord Darcy in a few places, in that they think what's happened so far has largely resulted in continuation of the status quo and hasn't brought about the sort of changes that might have been anticipated from the implementation of ICBs. And they talk about this. It's crucial to build this strategic commissioning capabilities, a strong focus on strategy as much as performance, and a parallel investment in skills required to commission care wisely, as much as to provide it well. So they're talking about strengthening that strategic, intelligent commissioning role of ICBs. And then there's allusions to the 3 shifts. What are they, Gandhi?
Analog to digital, illness to prevention, and
hospital to community.
Hospital community. There we go. Yeah. I always put them the other way around in my head for some. I can't remember. I like that one. I was thinking community 2, and now it's not community 2. It's the other way around. So yeah,
community is the destination. But they're definitely weaving all of those into all of the the policy and strategy documents that are coming out. There's some interesting. That's right. There's some interesting charts. Often, looking at the tables, looking at the charts is really the way to skim through these documents. So
the pyramids, I love the pyramid.
yeah, the pyramid is suitable here. I love a good pyramid. So they talk about this is to clarify the function of the different levels actually of within the NHS and where things sit. So it's interesting they talk about the national level, which will be NHS England, or within 2 years, I guess, just the Department of Health and Social Care. These are do-once functions, setting overall strategy, developing policy, and assuring performance, which I guess is different to monitoring. They talk about regional teams. We'll talk about this later, but I think these are probably the 7 NHS regions. We'll talk about where they are later and some of the roles that will land with the regions. So they talk about strategic workforce planning, digital. They're suggesting sitting here, which is interesting, and oversight and performance management of providers and ICBs. So the layer below, integrated care boards. So again, this word strategic commissioning to improve population health, reduce inequalities, and ensure access to consistently high quality and efficient care. And then there's the provider level. It's interesting what they list in here. Neighbourhood care providers. So neighbourhood is a key word that we see woven through all of these documents as well, which they define as primarily community mental health, voluntary, so VCSE, so voluntary community social, and what's the E?
Enterprise.
Enterprise. Okay, good. Working closely with acutes and specialist mental health and acute care providers. So obviously we're in the primary care ourselves as GPs, and providers responsible for delivering the high quality, safe, effective and positive patient experience and efficient care. That use of the word efficient as well. Interesting, because, you know, I've got a place role, as people might know. So it's interesting. So the places aren't specifically present within the pyramid, which is something that I observed. ICBs, particularly if they merge, as many anticipate, will cover quite large areas. So, you know, I wonder if there's an implicit, you know, need for place within that, or maybe that's wishful thinking on my part. We will see. We will see where the cards lie. But I think ICBs will probably struggle to interact with all of the providers, particularly smaller ones, directly without some intermediary level in between. So interesting. Any thoughts out there in eGPlearning land or with yourself, Gandhi, about the
So
general...
none from the viewers yet. I think they're still formulating it potentially and things. But I guess for me, one of the things that I reflected to you is that this just seems similarly going back to a slightly different version of what we had pre-Tory takeover. So, you know, effectively, the regional teams sound a lot more like the strategic health authorities. The ICBs seem to be not quite...
CCGs, they're big CCGs, aren't they?
Well, a bit bigger than that. Potentially a merger of the SHAs themselves, whereas the neighborhood teams and stuff is effectively becoming the PCTs. So are we seeing, you know, or potentially even more fund holding to a degree? So just a higher scale fund holding mechanism. So it sounds like we're going back in this circle to a different kind of time and things. And I absolutely agree with Dave's comment about we spent so much money reorganizing ICBs and they've just basically reorganized them again without saying they've reorganized them.
Yeah, I think that is what's happening, because it's a big change. I mean, they're talking about moving functions up and out, and you know, down and out to other organizations, and cutting the costs dramatically, really changing what the core functions are. So I think that's really true. I mean, whether or not it's necessary, I'm not particularly qualified to say, or have the right perspective to say, but they talk about there being a lot of variation in terms of how ICBs operate, how costly they are, and what they do. So there's that's an argument for this taking place.
And we're definitely having that coming through from the Egypt. So Dave McConnell, 100% that the wheel is definitely turning. And then Steve Taylor, who does some amazing infographics, 100% agree, regional health authorities.
Yeah, I think so. I mean, they talk about that region later on, which we're taking to mean kind of NHS England regions of, you know, east of England, London, Midlands, North and East Yorkshire, Northwest, Southeast, Southwest kind of areas. But I guess speaking of a wheel or a cycle, the next diagram is what looks to me like a sort of plan, do, analyze kind of continuous improvement cycle, and that's how they're representing the core functions of ICBs going through. Keywords here are system leadership for improved population health. So certainly we're definitely still in population health mode in terms of using data segmentation and you know, improving outcomes for populations. So one, understand local context. So assessing population need. They talk about using data, obviously, within the document, and, you know, good, strong data analytics functions and tools to understand the current situation and also model the future, to this, you know, intelligent commissioning, to understand more about the impact and model the impact of what we might do before we do it, and be smarter about that, and you know, use that to plan service provision. They talk about developing long-term population health strategy. So you know, that speaks to some of that modeling. They talk about functions. They talk about the functions that they should kind of grow and selectively retain and transfer out of ICBs later. But they do certainly talk about strengthening that, you know, that understanding and community engagement function, and how important that is, which I think feeds into developing, good long-term population health strategies. So they're developing that, and then they're delivering the strategy through payer functions and resource allocation. So commissioning that through the provider organizations, and the function here is to commission it, provide oversight and assurance of what's being commissioned, and then evaluating impact. So they talk about day-to-day oversight of healthcare usage. So the document talks about the usage of real-time data, dashboards to monitor system pressures, respond to those, and also for the management of the performance of the system and the providers within the system. So they talk about performance and contract management roles there, to ensure optimal value-based resource use and improved outcomes. So I think they're talking about value for money, and they're talking about improving outcomes for patients and populations. So that's, again, if you're jumping through the document, that's the second important diagram to have a look at. The next bit is the table, which is worth actually going through. And,
is probably the best way of describing it, because there's multiple of them, isn't there, Andy?
Yeah. So it's quite long. Do you want to pause, Gandhi, or shall we go into the table?
I think we're probably better we crack on, because time's a ticking. I'm just going to comment from Steve. Again, he's coming with the comment, the good thing you only have a few people around the national table for quicker decisions. I guess that's possibly a consideration in terms of how it looks like, but it seems like the decision is still going to be made by the Department of Health. It's, that decision-making power is shifting upwards towards them, and then downwards is the regional teams to do the doing, and the ICBs to do the thinking, and then the neighborhood teams to deliver. That's my understanding of how this is looking.
Well, so this big table is really interesting, and it kind of categorizes what ICBs currently do. I guess some ICBs will be doing all of these things, some won't be doing all of these things, and it talks about where these things perhaps ought to move to in the future. So it's categorized as things to grow. Oh, sorry, I've jumped ahead to the next table, and I think we will move to the next table, actually. So this is providing more detail on the core functions. In fact, let's just say the headings here. So these are basically those different 1, 2, 3, 4s of the diagram that we saw before, to provide a bit more detail about what's in them. So understanding local context, they're talking about population and data intelligence, forecasting and modeling, and reviewing existing provision. So you know kind of what to change, and what you've got, what to change, what not to change. 2, in terms of developing long-term population health strategy, they talk about developing the strategy with options for testing and engagement. They talk about setting this strategy as well. And then that 3, they're talking about delivering the strategy through payer functions and resource allocation. So strategic purchasing. Okay. So they talk about, as you said before, it's a lot about kind of outcomes, using data and focusing on outcomes less than activity. Market shaping and management is really interesting, actually. So there's statements like introducing and encouraging new providers where gaps exist in the market, for example, frailty models. So that's interesting. There's perhaps space and gaps for new providers to come in, or existing providers to take on new functions,
potentially,
perhaps even that traditionally sit with other parts of the system. So there's some interesting things in here.
True. I mean, the part that I found most interesting about that one is actually the comment above it. So building robust should cost and should deliver models to test against. So is this potentially looking at the actual cost of delivery of healthcare in some ways? Because one of the comments often made by general practice is often that we are underpaid for the work that we do. Actually, if it's proven that actually it does cost this amount to deliver healthcare, does that then equate to that's where the funding will flow to?
And I guess that, I interpreted that a little bit differently, actually. So I think that's perhaps an optimistic interpretation. But, when you do the analysis, that might be the outcome. I was thinking, actually, we're like, well, we're paying the, let's say the word hospital, to do this intervention, or provide this service for us. Actually, what should that cost? What should that deliver? And does it? And do we need to resize the contract around that? That's how I interpret it, which is the negative way of interpreting it. But I guess it could swing in both directions. So interesting. So market shaping and management, I think that's a really interesting area, actually. And then contracting. So we come to contracting and looking at the payment mechanisms as well. So, and they're talking about, monitoring performance, benchmarking. I think the word dashboard, is in here somewhere as well. And in terms of payment mechanisms, designing the right incentives to improve equity, efficiency, and productivity, risk mitigation strategies. So kind of pooling contracting risk with providers. I think I'm interpreting, some of that activity there. So really interesting. And then that fourth area of evaluating impact. So they'll be looking at a number of areas. So utilization management. So I think that's kind of what are the current stresses on the system, who's using what, are things being utilized. They talk about unwarranted care variations. So you often hear this in these documents. People should get the same service in one part of the system as they do in another, and using tools to highlight and combat and redress that. Evaluating outcomes. So that's outcomes. So I guess that's activity, utilization management, and outcomes. And then of course there's the area of user feedback and co-design. So they're interested in those community elements as well. I guess what isn't on the picture that we saw before is the governance, and core statutory functions, which it outlines here as well. I heard an intake of breath, Gandhi. Was that you about to ask a question?
No.
No. Okay, good. So I was wanting to get to the functional changes table. So
just before we get to that, so Steve Taylor talking again, and some really cool stuff. So vital about people understand the data. The truth is GP is inputting most of the data and we know what's missing, e.g. it's only counted in appointment data if it's in the appointment books, and that GPs need to highlight gaps in data recording, otherwise focus will be on counted data. We've mentioned this time and time again. If it's not counted, people don't care about it. So there is this aspect of making sure that data is correct.
Yeah, exactly. For example, if a system is, or a neighborhood is looking at a frailty intervention, but frailty is not coded, well, then that really undermines, the work, essentially. So, so thinking about how you get that data coded correct is really, really important. So, yeah, thanks, Steve. So, so this table, I guess, I guess for people with an ICB role, this table is really interesting, and it's interesting to the rest of us as well. So this looks to kind of go through the sorts of functions that ICBs currently do. And as I said before, some ICBs might do all of these things. Some ICBs may do some of these things already. And it categorizes them in sort of three ways, really. So it talks about grow. It says, okay, ICBs should be investing in their capabilities to do these things. It talks about some things to selectively retain and adapt, which I guess is the level down. So I guess they're considering those less essential, but still needed. But maybe people need to. So retain and adapt. I mean, that might mean maybe you don't need to dedicate as much resource to this. If you're reading the document in that way, and then review for transfer to other parts of the system. Is how some things are categorized, and the sort of destinations they talk about are so things outside the ICB, such as national level, the regional level. So we're thinking that's probably the 7 NHS regions, and providers. I mean, again, what do you think they mean by providers? We had a little talk about this before we went live.
I'm still a little confused as to, and I think somebody else made this comment about, was Dave McConnell making this comment before, possible to devolve these functions down to providers, when we don't really know how these providers are going to work together, what they look like, what it's going to function as and stuff. And I think there's an element of responsibility being given to people who are doing the doing. So how is that going to work? It speaks to an element to me of fund holding almost. And there was a reason fund holding worked and also didn't work when it came through. So it's just understanding how that is going to look. But I think, this is the practice teams. This is the PCNs potentially. This is the partners, the hospital trust, the community enterprise teams, and that kind of stuff. And yeah, I still feel it's a little bit icky.
Yeah, I mean, I guess it's unclear, and this kind of national guidance often allows for kind of regional and more local interpretation. That's how it often works, to provide that flexibility. Yeah, I mean, I can see it maybe being like, say the function is population health management. Maybe they want to sit that within a community provider, like a provider of nursing teams, or a federation, or sit that with a hospital trust, if they feel they're capable. Then you also wonder, like, is the funding following that team, or are they just delegating the responsibility? And that was something that was not quite so clear to me.
I guess I'm just partly concerned that I can see a lot of splintering of care happening, because ultimately who's going to be in charge of making sure it happens? And that's the bit I'm not quite clear on, because it doesn't sound like it's going to be the ICBs anymore.
Yeah. Or they're delegating that function, and they're going to monitor and evaluate and ensure it's delivered in a cost-effective and efficient and impactful way. Yeah. Shall we have a look at some of the things on the table? Because I guess it'll become apparent. There's quite a lot there, so we can't go into everything in detail. But so the things to grow. So these are things which I think they're steering to definitely kind of stay and sit with and be core to ICB functions. So population health management, data analytics, modeling, risk stratification. So that seems essential. Epidemiological capabilities to understand causes, management, and prevention of illness. Sounds a bit sort of public health type function. To me, something that currently sits with public health. So that's interesting that's included. I've not heard that public health is moving to ICBs, but interesting. Strategy, strategic planning, working on health inequalities and inclusion, and developing expertise about managing that and improving that within the system. So that's interesting, providing the expertise to guide evidence-based interventions and allocate resources to be effective in that area. So a lot of these are functions and kind of skills that maybe ICBs need to, continue to build and invest in. And I'm sure they've been growing these over the last few years. Commissioning of neighborhood health, commissioning of clinical risk management, commissioning. So a lot of commissioning functions, commissioning of pathways, vaccination screening. Screening will be delegated by NHS England to ICBs, or remaining NHS England direct commissioning functions will be reviewed. 25-26 core payer functions. So they talk about strategic purchasing, contracting, payment mechanisms. So that sounds like strategic commissioning, probably. Evaluation methodologies and evidence synthesis using qualitative and quantitative data. So actually quite technical functions here. User involvement led design. So that feels like engagement with communities, and I guess managing strategic partnerships. So those are definitely core. There's quite a long list of selectively retain and adapt. So the sorts of things in this area are quality management, understanding drivers of improved health, range of outcome measures, elements of high quality care. So quality management, board governance. So look to streamline boards to deliver core role as set out. Headcount should be reduced at board level. So I think they may be thinking there are too many boards that occur. Clinical governance. So you think this sort of thing is pretty core, but maybe they're thinking that can sit closer to the delivery with providers, with ICBs providing the oversight potentially. Again, we're only sort of selectively retain and adapt. So maybe we're talking about areas that are still with ICBs, but maybe looking to be done differently, or dare I say it, smaller, given that we're expecting running cost reductions. Corporate governance, let's just say the names so that people know what's in there. Core organizational operations, that's like your HR, comms, internal finance, audit, procurement, complaints, PALs, existing comms functions, and then review for transfer. This is also a large area. So I guess this are things that might be done outside of the ICB and in other locations. So oversight of provider performance under NHS performance assessment. So I think they're saying that's going up to national, I think. So the destinations over here, maybe I've got that wrong. Have I got that right? Going national? Marketing management retained and grown in ICBs. NHS performance and assessment matrix. Oh, regions. There's the word region there. So
yep.
That's going, so maybe one of the 7 regions. Emergency preparedness, resilience, response, regions over time. High level strategic workforce planning, development, education, and training. Regions or national going to.
Which those two do make me slightly concerned, because those things moving to a much higher level tends to mean that they're not as responsive from my perspective in terms of how that will work on the ground. So, you know, we saw emergency preparedness and resilience and response, how important that was during COVID. And actually there was lots of criticism that we weren't prepared because a lot of the attention had been taken away from it. And moving that higher up rather than closer to the ground raises questions of, if we were to have another public health emergency or something along those lines, how quickly will that information flow in terms of what to do? In terms of strategic workforce planning, the workforce planning has been awful. You know, why would you take it further away from the place it needs to be delivered from? Surely it'd be better to bring that further down and actually have that on a lot more local level to make sure it's fitting the needs of the population.
Or alternatively, you know, does taking it up give you economies of scale and greater depth of skills and expertise to get it right? Some people might say. I'm not saying that that's my position, and I'm not positioned to say which.
No, me neither.
To say which is best. To be honest, there's arguments for both. Research, development, and innovation, regions over time. It's interesting. Green plans, sustainability. So providers. So these are things that are kind of going. I'm using the word down. I'm not sure that's quite the right word, but to the large providers. And I guess we've named some of the sort of providers. We've seen kind of efforts to develop provider. What's the word?
Collaboratives.
Yep. So it's probably the components of the provider collaboratives. I'm thinking. Or the provider collaboratives themselves sharing functions that they may be talking about here. Digital technology, leadership and transformation. So providers enabled by national data and digital infrastructure. So that's interesting. So kind of ICB in the middle, potentially not as involved in that. Going up and down. Data collection and management, national over time. Okay. Infection prevention control. So maybe transfer some of these activities out of ICBs. It doesn't say where to. Safeguarding, transfer out of ICBs or streamline. SEND. I forgot what SEND stands for, Gandhi.
Special education needs.
Special education needs? That's SENCO you're thinking.
Is it?
Certificate? No. Anyway, no, maybe you're right. Special educational needs and disability. Maybe. Okay, I'm not sure. People can maybe tell us in the chat. Development of neighborhood and place-based partnerships. This is neighborhoods. Transfer to neighborhood health providers over time. So that function potentially sitting within providers. Primary care operations and transformation. Neighborhood health providers. Medicines ops. Transfer to providers, but retain some within strategic commissioning capabilities. Pathway and service development programs transfer to providers, but retain strategic commissioning overview. NHS continuing healthcare, test and explore options to transfer out. Estates and infrastructure. So that's quite big and important thing that needs a lot of work. Transfer to providers over time, but retain the strategic commissioning overview and strategic function. And general practice IT, explore options to transfer out of ICBs, ensuring a consistent offer. So not really sure about the destination there. So it's interesting. I do wonder where estates will land. And I always, with these, I do have that question of, you know, how much of the resource that currently goes into providing these, you know, will come to the providers to provide these functions. That's a question.
Absolutely agree with you on that. It's challenging to understand in terms of what that's going to look like, and function. And I know when we discussed this beforehand, I kind of said to you, well, I'm slightly confused because I don't know how much of this is going to actually lead to system change in comparison, because so much of it is, explore options, but we don't know where it's going to go just yet, kind of thing.
Yeah. Should we take a few comments from?
Yeah. So Steve Taylor, again, it depends how good people are in decision-making positions and how good they are at understanding the issues on the ground. Definitely need GPs in these positions, or those that understand community primary care. GP voice needs to be heard.
Yeah, here, absolutely. And it's going to be quite interesting to see what happens to clinical leadership as ICBs are reducing their running costs, and whether clinical leadership roles, to what extent clinical leadership roles may or may not be removed, alongside other elements of the headcount. I don't know. I think it's clear that clinical leadership is required to deliver on those core functions, but there's a lot of other expertise that's required as well. So I think that table is the main kind of interesting thing within the document. The last two sections it talks about kind of key enablers and capabilities. So what do ICBs need to do or invest in to deliver on the core functions and the change that's needed? And in here they talk about investment in healthcare analytics, in strategy capabilities, in intelligent healthcare payer. So I think that means smart commissioning, essentially. User involvement and co-design. So listening to communities, listening to people and being responsive. Clinical leadership and governance. So maybe that in part informs the question I was just asking about the role of clinical leadership here. I think Dave McDonald, this is probably a comment about clinical leadership, saying trim down already. Sad face. Potentially system leadership for population health, so focus on population health, and partnership working with local government, so improving those connections with, or maintaining and improving those connections with local government. And the last key enabler here is supporting ICB competencies and capability development, national support offer, and maturity assessment. So I love a good maturity matrix, so I'm sure we'll have one of those for ICBs coming down the line. So they're talking about a national program to give ICBs what they need in terms of the competencies and capabilities to achieve this change. And then the final section is just about managing the transition. So it talks about, I guess, things to get right as you're managing the transition, and some of this is to be expected. So it gives really some high level principles around delivering the cost reductions, planning for that, and actually realizing the savings, managing the impact on staff. So we kind of alluded to this, throughout it, that this, where we talk about functions and transfers, this is people's jobs. So this is really important for the staff. So managing the impact that it has on those staff. And within that, I talk about actually, retaining the right functions and the right staff throughout the process, as well as those reductions in headcount that are discussed, designing leadership structures of ICBs. So that's really important, and managing risk during the transition through safe governance. So making sure that balls are not dropped during the transition process, and it talks about expectations of safe transition of transferred functions. So I guess that's making sure that functions that are moving out, land properly in their new destination and function there. So, an interesting document. Hopefully we didn't ramble on too much, but I think it's quite big, because this is a huge change to ICBs, which are a huge part of how we deliver healthcare in the country.
Absolutely. And I think punctuated by that last kind of comment that you can see just there about the fact that they need to bring the affordability down to £18.76 per head, as Andy mentioned earlier, that actually, this raises a question of how much is that a reduction by? Well, different areas, it's something like £47 to £21 per head currently spent. So everywhere's looking at potential reductions, but some places much more significantly than others, potentially.
60 to 70% reduction somewhere. That's quite a lot for an organization.
And that raises the question of the service delivery that's going to happen as a result of that, in terms of what will patients see, what will the population see, what will practices see, what will organizations see, all those kind of things in terms of the impact this is going to have across the board. It's going to be seismic.
Yeah. Any final thoughts on all of that, Gandhi? There's quite a lot to digest there, I think.
There is. I mean, I think there's a lot to digest. I think it's challenging to understand how all of this is going to land and fit. And I think this is dovetailing, and we keep mentioning it. The 10-year plan is the next big document to come out, and that's the one that I think is going to direct a lot of the more superseded kind of changes and things. But I think it gives direction of this new makeup that we're seeing in terms of what healthcare structure is going to look like, and I think that's going to be a real challenge. And I think absolutely Steve's making it clear that the public needs to be aware of this cut and the implications, because I think this is going to mean reduced healthcare delivery, because I can't see any other way you can have those level of cuts, even with the system change that they're planning.
Yeah, I mean, the risk of dropping the ball as functions move around, as staff move around, of actually being, at least maybe for a short period of time, maybe longer, kind of less effective at those core functions of, strategic and smart commissioning that actually meets the needs of populations. There is definitely a risk there, which I guess the document talks about mitigating, but can you mitigate that completely? Yeah. I'm not sure. There's definitely a challenge there. So interesting if people have comments, if they're watching this after the event as well, to put in the chat below. Yeah, gosh, probably need a cup of tea in a minute, Gandhi, after that.
Definitely. Well, I think just to finish off, so we're just going to go through a really quick super summary of what we've covered today. Do you think we're up for that, Andy?
Yeah, go on, you do your bit.
Okay,
I'll do the bits I led on.
So in this episode, we talked about a couple of different things. Well, first we talked about was the value of general practice. So this is off the back of the document released by the BMA and the GPC after the LMC UK conference, talking and emphasizing the value of the general practitioner. In particular, looking at focus on continuity of care, driving it through how much cost-effective benefit that has to the system and to healthcare if it's achieved, and that actually general practice is best placed to deliver not only continuity of care to patients, but also the availability to help understand their patient needs and drive forward that illness to prevention process in terms of the government's plans, focusing on the fact that that is GP-led and GP-provided, and recognizing that additional roles, whilst can be useful in certain circumstances, often the cost-effectiveness of them may not always be just about the nominal value of those costs themselves. Emphasizing that by delivering more resource to general practice, like I said, the return on investment is almost 14-fold based off the evidence we currently have. So why would you not want to do that? This document is something I think that needs to be shared with practice teams. This document needs to be shared with members of parliament. This is a document that you can use to back up the fact that general practice is good at what it does when it's properly served and provided for. And actually, if you were to start doing that, we may see the benefits that will offset some of the concerns in the later document that Andy's going to talk about. Before we get to that, I'll cover the other one, which was the the collaboration between Exon Surgery Connect and Tortus, which is an ambient voice technology or ambient scribe provider, in their new offering, which is Tortus Surgery Intellect, which is basically an integration of the two tools. It sounds cool, waiting to see what this is going to cost, but this is provision of service to various different places, with 10 ICBs leading the way, and then future access later on in June potentially. And we talked about how collaborations have an impact in general practice and what's going to be next in this collaborative matrix that we're seeing across the board. And that leads very nicely into a Model ICB Blueprint, doesn't it, Andy?
It does. So the final thing that we spent some time talking about was a document that was kind of leaked through the HSJ, which is a Model Integrated Care Board Blueprint version 1.0. So so ICBs are going through a huge change at the moment. There's a 50% running cost cut on top of a previous 20% running cost cut. So ICBs are being asked to reduce their running costs to £18.76 per patient from anywhere between £49 or £21 per patient. And this is not the total healthcare spend on individuals. This is the running cost of the ICB per head in terms of coordinating that spend to deliver good care. This document was produced in collaboration with ICB and system leaders from different types of system across the country in a sprint of 2 to 3 weeks, we think. It focuses on the areas of like why ICBs exist and providing clarity around that, on what the core functions are and what the enablers and capabilities are that need to be in place to ensure that they could be successful in delivering those core functions. It also spends a large area managing the transition to that. We were sensitive, or at least we hope we were sensitive, that whilst we're talking about functions and roles, these are people's kind of jobs essentially, as there's a big kind of restructure happening at ICB. So hopefully we were sensitive to that. This document provides context to what's happening. There are some great diagrams in it talking about where and really providing clarity about what ICB's responsibilities should be to reduce the variation that they say exists in terms of what ICBs are actually doing up and down the country. It talks about the new core functions, which are understanding local context, delivering long-term population health strategy, delivering the strategy through payer functions and resource allocation, and evaluating the impact. It has a big table that looks at existing functions that ICBs may or may not be delivering all of at the moment, and talks about those that should be grown and invested in, those that should be selectively retained and adapted, and those that should be reviewed for transfer either up to national or regions, or down to providers or to destinations unknown. The key theme in this is the word strategic commissioning, which appears to be the function of understanding what is needed, developing a plan to deliver it, delivering it by commissioning and allocating the resources efficiently, and then monitoring and evaluating the impact and performance of the system, and then go through the loop again and continually improving that. I think we can probably wrap it up there, Gandhi. It was quite an action-packed episode.
It was. And thank you as ever to those who stayed with us to watch all of this live. So definitely thanks to Steve as he thanks us for delivering this episode. As ever, me and Andy will be back in a couple of weeks' time to cover whatever else is going on soon. We know that the 10-year plan is going to come out shortly. It's penned for June. When in June? Who knows? But there's tons more content coming out on the channel in the next few weeks. So don't worry. If you haven't subscribed, this is the best time to do it. You're going to get some awesome content in the next few weeks as well. Trust me on this. Whether this is about learning, whether it's about technology, whether it's about governance, everything to do with primary care. We've got loads of stuff for you. And as ever, we'll be here to take an answer to primary care and learning. We'll catch you next episode.